Well, it's always just a real treat and pleasure to welcome Dr. Lynn McPherson to present to our program. Those that have been involved with the HPM field, no introduction is necessary for those that are new to Dr. McPherson. She's simply one of the leading experts on hospice and palliative pharmacology in the world, and it's just been a delight to work with her in various capacities over the years, and she's graciously agreed to share with us here today. So I'll turn the mic over to you, and you can impart your incredible wisdom to us here.
Thank you, Dr. Mulberry. Well, it's a pleasure to be with you. And I'll apologize now for my voice since I'm just getting over COVID. Um, that's what my sister gave me as a holiday gift. So thank you so much. So we've got a lot to slog through today. Three main buckets of information: deprescribing, medication tips, and some new drugs from 2024 that I thought were pretty interesting and why I think they're interesting. So this should keep us out of trouble for about an hour. So these are my learning objectives, which just share what I just already said. Feel free to jump in at any point, unmute, whatever you'd like to do. Okay, so we're going to start with the whole deprescribing thing. So thanks to advances in medical science, we are living longer, which is great, but we are living longer with multiple comorbid conditions, which is going to require more drug therapy, more complex therapy. So the definition of polypharmacy, which is pretty variable. Some people think it's 5 or more drugs. Some people think 9 or more. One of my students thought it was a patient who went to more than one pharmacy. I guess it could be that too. But generally, the literature says people taking 5 or more medications. But it's still, there's some subjectivity there. What do you do with the PRNs? Do they have to take it regularly for it to count? Do they just have to have it in their house? So it is a little goofy. But anyway, as you can see, the prevalence is certainly increasing from a little over 8% in the year 2000 or so. And then about a decade later, it almost doubled. So I would hazard a guess that now it's gone up even more. If you look at long-term care facilities, you can see pretty much everybody is on at least 5 drugs, and the majority are getting 9 or 10. And I think indisputably, the polypharmacy carries an increased risk of medication-related adverse effects. So when you look at older adults in particular, not only the increased risk of adverse effects, but it heightens the risk of frailty, delirium, cognitive decline, disability, hospitalization, and actually mortality. I read something the other day that we shouldn't talk about lifespan, we should talk about health span, which is how long are people living, and they're in pretty good shape. So I thought that, well, that was a laudable goal. I want an increased health span, not just lifespan. I mean, you have to admit, we see people sometimes on hospice that are so bad. I actually pray they die sooner rather than later because it's so sad. So, what is the scoop with us in hospice and palliative care? What would you think? Do you think when patients come to us, we add more medications or do we take away medications? I mean, that's a conundrum there. And when you look at the drugs that we use, they have a high sedation burden, a high anticholinergic burden. And often these folks are elderly. I think our average age on hospice is mid 70s. So certainly a lot of risk there. So do people take more drugs as they approach the end of life? Are practitioners stopping medically futile drugs in advanced illness, such as drugs that slow diseases, like the Alzheimer's drugs, for example, preventative meds like the statins? Certainly, we would all agree that patients at end of life are frailer than the general population, and they're at greater risk for medication-induced adverse effects. Often they have reduced renal or hepatic function. And then we see all the age-related changes in pharmacokinetics and pharmacodynamics. I thought this was interesting. This was a study done in Sweden. In the year before death, the percentage of patients taking 10 or more drugs increased from 30% to almost half of them. That is crazy pants. So if polypharmacy is the problem, what's the solution? Well, obviously, if we have somebody on too many drugs, we have to withdraw some of the drugs. This has been known as de-intensification. I love this geriatrician salute. And of course, now we refer to it more commonly as deprescribing, which is defined as the process of withdrawal of an inappropriate medication supervised by a healthcare professional with the goal of managing polypharmacy and improving outcomes. So, I mean, I think we all know what it is, but if you look at the little diagram on the bottom, the prescribing continuum, I think while we inherently know this, I think patients don't know about this. I mean, when someone presents to you in your practice, you're going to do a patient evaluation. And this is I'm not talking about non-pharmacologic interventions here. I'm focusing on drug therapy. You're going to think about things about that patient in front of you and things about the medications that are kind of on your short list that you're choosing from to treat the patient. And then looking at that patient and the drugs you're considering, you make a decision to pick a drug. You start the drug, you may have to titrate the dose, and you're going to see how they do. And then you're going to make the decision, should we continue it, or maybe we need to move on. So if it's something like, if I had high blood pressure and you said, well, you've got high blood pressure, I think we should try HCTZ 25. And I said, okay. And then you tried it, and then it didn't really do that great. And you said, I think we should switch to lisinopril. I'm not going to cry and get all upset about it. I would be like, okay, let's hope the second one works. But the stakes are so different in our population, aren't they? The meaning of drugs certainly is heightened. So what are some of the views, attitudes, barriers, and enablers? What do patients say? Most patients, as you can look at this data here, 80, 90% said if their prescriber is good with it, they are absolutely good with stopping a medication. Sometimes the family is the problem, not so much the patient, but most people are on board with this. What do physicians or prescribers say about this? 75% say they are confident in deprescribing, but not as many are comfortable stopping a guideline recommended medication. And 40% of physicians are reluctant to stop a drug started by a different physician, especially if it's a specialist. 45% of physicians are reluctant to stop a drug that the patient or caregiver thought was important. When I sit in a hospice team meeting and I hear the nurse describing something to do with the drug, and I say, oh, for God's sake, why is this patient still on this drug or whatever? And they'll say, the daughter wants her to continue. And I'll say, well, who's in charge here, the daughter or us? And they all smile at me and giggle at me like I'm not quite right in the head. Because in home hospice, you know what? You like to think you're in control, but I have sad news for you. A lot of physicians feel like deprescribing is swimming against the tide. There are so many barriers. So let's see, this is a survey looking at 321 physicians who were looking at prescribing practices at end of life. And 3/4 of them agreed patients at end of life get too many drugs. And then in the study, they gave them a hypothetical case, and there was tremendous variability in their decisions in deprescribing. So I think when you look at considering drugs in a serious illness or at the end of life, what data informs that decision? I think these are the pieces of information you need to garner. What is likely the patient's remaining life expectancy? When you're thinking about starting a drug, what is the time to benefit? Then you have to consider the patient and family's goals of care and what specifically is the treatment target. When I teach my pharmacy students, I remind them you can't just go willy-nilly into drug therapy. You have to have a therapeutic goal. So how will you know if this drug is getting the job done? I think it's important to know the number needed to treat and the number needed to harm. I mean, there are some drugs like those anticholinergic drugs we use for overactive bladder. When you look at the number needed to treat and the number needed to harm, you are more likely to cause harm than benefit. So that's an important consideration. And then look at drugs where once you stop the drug, you continue to have a persistence of benefit, like sort of like a post-antibiotic effect. So Holly Holmes, who's a very well-known geriatrician, and she's worked in palliative care too, at MD Anderson. No, I'm sorry, she used to be at MD Anderson. She's in Texas, still in Houston. Published this years ago, just kind of pulling all that data together. So I'm not even sure what kind of geometry shape this is. Is it a rhombus? I'm not quite sure. Anyway, if you look at the bottom, appropriate medications, that platform there is larger than at the very top, the same little square, because people at the bottom have more time left. They're still pursuing curative therapy and so forth. People at the top have a shorter prognosis, and they're more interested in palliative care. So as you can see, what goes into this decision should be their life expectancy, time to benefit, goals of care, and the treatment target, which when you look at someone with less and less time, they should be on fewer drugs. So I came up with this little algorithm here. I think it's important that you do this with every single drug you're considering starting on a hospice or palliative care patient. So the decision to start a new medication or not. Number one, estimate the patient's life expectancy, estimate the medication's lag time to benefit. So here we're talking about starting a new drug. So as you consider those things, if their life expectancy is less than the lag time to benefit, in other words, if we start this drug today, it's going to take, like if you look at the thiazolidine diones, which is probably not big in your world, but it's like rosiglitazone, pioglitazone, they're for diabetes. It takes about a month to really see the effect of that drug. So if this patient's going to be gone in a couple, 3 weeks, it's unlikely to be beneficial. Why would you even go down that road? If the life expectancy is about the same as the lag time to benefit, I don't know. That's a maybe. I'll put that in the maybe bucket. And if the life expectancy is greater than the lag time to benefit, I would still put that in the maybe bucket. I think you need to evaluate there the patient's goals of care. What are the treatment targets? I mean, is it really appropriate to go for, a very specific target that you would look at in somebody 20 years younger? So here's one example. A 68-year-old man admitted to hospice with a diagnosis of end-stage colon cancer. Non-opioids are no longer relieving his pain. A prescriber would like to start oral morphine solution. When you think about that process we just went through, you don't have to unmute, but give me a thumbs up if you think, yes, we should start the morphine, or yeah, not so much. What do you think? Thumbs up, thumbs down. Okay, good. I see some thumbs up. So his life expectancy is about 1 to 2 weeks, let's say. The oral morphine solution lag time to benefit is less than an hour. So clearly, his life expectancy is greater than the lag time to benefit. And his goals of care are, I want you to relieve my pain. And he may have a specific treatment target. Yesterday, a nurse called me and said, this patient's very unhappy with his medication regimen. His pain goal is 2 out of 10. And currently, it's a 3 or a 4. I was like, well, girl, I thought that was pretty darn good. Last week, we were in an 8 or a 9. So I thought we were making good progress. So anyway, yes, I would begin the oral morphine solution. So now the same patient has a history of stage 1/2 hypertension for the past year. For the past week, his blood pressure has ranged from 140/90 to 150/95. The prescriber, who's not a hospice palliative care person, is considering starting lisinopril. Life expectancy, again, a week or 2. The time to benefit, yeah, that's going to work within an hour. Would you start lisinopril here? Oh, I got a thumb down. Yeah, I agree. So the question is, how long does a patient with have to have hypertension before you start to see end organ damage? Now, I gave you the blood pressure to rule out hypertensive urgency or emergency. So generally it's years. So if this guy's got a week or 2 left, obviously. So if it was a blood pressure of 180/120 or higher, it would result in an 80% chance of death within a year, with an average survival of 10 months. So even if his blood pressure was considerably higher, and hypertension is a silent killer, right? All right, how about looking at meds that people are already on? How do we go about stopping medications in a hospice or palliative care patient? This is a terrific article here by Thompson et al. It talks about these 3 different levels of approaches to deprescribing. So the first is just having this model or framework. The next is looking at the entire medication list. And the last is medication-specific guidance. So I think this is really important. I mean, at the end of the day, sometimes when I'm wrestling with, should we start this drug or should we continue this drug or whatever intervention it is you're considering, sometimes if I'm not sure we should do it, I take a step back and say, is this going to make a difference for the patient? Is this going to lead to a patient-important outcome? I love that term. I mean, I don't want to dig around with drugs that are like, you could, or maybe you don't have to, whatever. I want full court press, a patient-important outcome. So I do think it's very important. It makes me crazy when maybe a nurse calls me, for example, and says, you have to help me with this, and describes the sitch, and I'll say, well, why is this patient on this drug? I remember once I was in team meeting, and the nurse was describing the patient had a lot of nausea. And I looked down at the drugs. The patient was on Dig. So I said, why is this patient on digoxin? And the nurse looked very hunted. She kind of looked around like, oh, my Lord, I can't believe I have to do this. And she kind of leaned forward and lowered her voice and said, Lynn, that's a heart pill. I was like, girl, I know it's a friggin' heart pill. I work at a school of pharmacy. Why is this patient on this heart pill? She's like, oh, I don't know. Because obviously, although we don't use DIG that much anymore, the target serum level for AFib to lower the rate is higher than what we would use for somebody with heart failure, even though we don't use it that much anymore. So for every drug the patient is on, you have to know what is the indication for this drug for this patient. I mean, you look at the ACE inhibitors, there's a bunch of indications. You look at the GLP agonists, if you look at approved and off-label indications now, it's everything but the heartbreak of psoriasis. So why is this patient on this drug? The next question is, are they taking it? Often we go through this whole thought process and thump our head on the desk only to find out the patient's not even really taking the drug. So if they are taking it, and you know why they're taking it, what is the treatment goal? What's the target of this medication? And then before you move on, say, okay, is that reasonable given this patient's life expectancy and how long it takes for the medication to bring something to the table? Maybe it was a recently started medication. If the answer is no, that's not a reasonable target. So like yesterday when the nurse called me about the guy whose pain was 2 and it was already, he wanted it to be a 2 and it was a 3, I did not feel compelled to bust a major move with that. But if you're not reaching the goal or it's not appropriate, discontinue the drug. Taper, perhaps, if it's appropriate. But if the answer is yes, so is that target goal, now that we've said, yeah, there's benefit to reaching that target goal, is this consistent with the patient's goals of care? If the answer is yes, then you go on to the next question. If the answer is no, I would stop it. If the patient says no, I don't want to go there. So if it was yes, is the medication causing significant toxicity? Is it contraindicated? Or are we using this drug to treat drug-induced disease? Because if the answer is yes, you probably should stop it and then maybe address the drug that was causing the original problem. If the answer is no, then you have to ask yourself, is the medication causing greater adverse effects than symptom relief, or does it have any potential future benefit? If it's causing greater adverse effects than symptom relief, stop the drug. If the answer is no, then you go ahead and continue the medication. And I know it took 5 minutes to go through this process right now, but it's sort of like the first, think back when you wrote your first soap note. How long did it take you to write your first soap note? I think when I was a pharmacy student, it took me all weekend long. And now you can write a soap note in about 2 minutes flat. So my point is, this feels cumbersome looking at this, but it sort of becomes inculcated into your mental critical thinking process, and you can just blow through this. But it's sort of like you go through it very, very quickly. All right, so let's look at a couple of examples. What the heck is metabolic syndrome? Well, half the country has it, so I'm sure you know what it is. It's a group of risk factors that raise the risk of heart disease, diabetes, stroke, and other health problems. And according to the American Heart Association, about a third of all adults have it. So according to these groups, there are 5 risk factors that make up metabolic syndrome. To be diagnosed with metabolic syndrome, you have to have at least 3. So built like an apple, high triglycerides, low HDL, hypertension, hyperglycemia. So let's meet Mr. Herndon. He's a 76-year-old man admitted to hospice with stage 4 non-small cell lung cancer. His prognosis is 4 to 6 weeks, according to his oncologist. He has comorbid conditions of diabetes, hypertension, chronic kidney disease, dyslipidemia, and an 80-pack-year history of smoking, but he stopped a year ago when he was diagnosed with lung cancer. His primary goal is to be kept comfortable, but he also wants to live as long as he can. Here's his drug history: atorvastatin, metformin, Lantus, and Novolog sliding scale, which makes me stark raving insane, lisinopril, amlodipine, a multivitamin with iron, which is, I think, federally mandated now that everybody and their mother has to be on a multivitamin with iron, acetaminophen, a long-acting oral morphine, morphine solution, and Senna. So he's 5'10". He weighs 165 pounds at present. He has lost 100 pounds since diagnosis. His waist circumference now is 34. His recent fasting was 74. His triglycerides are 140. HDL is 30. He hardly ever uses the sliding scale. As a matter of fact, he complains of hypoglycemic symptoms occasionally. And although we are not going to get an A1C, 6 months ago it was 6.9. His blood pressure is about 120/70 when he's seated, but he says he gets woozy when he stands up. When you suggest slimming down on his medication regimen, he gets very upset and cries, "What? My heart doctor and regular doctor said I had to stay on these medications till the day I die. Are you saying I'm going to die tomorrow?" You young whippersnappers are always upsetting the apple cart. So, young whippersnapper, what do you say to that? Well, let's look at each of the drugs. So the multivitamin with iron. I'm sure we would all agree we probably don't need this one. But if he feels really strongly about it, if he thinks it's keeping the wolf from the door and it's not causing him problems, I'm not going to argue with him about it right this minute, but I am going to keep an eye on it. I would explain that the iron and the vitamins and minerals are probably increasing his risk for constipation and can cause a little nausea. The iron can be turning his stools dark. So is he bleeding internally? Probably not, but I mean, it's unlikely. So let's let him cruise along with that for the moment. But look how big those suckers are. I mean, a multivitamin with iron is generally the size of my shoe, so it could be a choking hazard too. Now, analgesics and laxatives. So here's an interesting little pearl for you. In the Scandinavian countries, when someone's diagnosed with cancer and they have pain, they automatically start them on 4 grams of acetaminophen. At least this used to be the practice, regardless of what else they need for pain control. And finally, somebody said, there's got to be some point where if they're also on an opioid, can they really tell the difference with or without the acetaminophen? So several studies were done, and the answer is no, they can't. Once they get to about 60 to 70 milligrams of oral morphine a day, they can't tell the difference with or without the acetaminophen. So I would probably stop that acetaminophen that he's taking. I would certainly, look at his wishes. Does he have liver disease? Does he have a history of alcoholism? Is the morphine getting the job done? And is the senna maintaining normal bowel function? Now, I will admit sometimes we'll have a patient with pain from their admitting diagnosis, but perhaps they're using acetaminophen for headache or something, and it seems to be working. That's a different thing. But if this is just, day in, day out, he probably doesn't need it.
Dr. McPherson, are you still projecting slides because somehow the screen share disappeared?
I am, yeah. Let me reshare.
Thank you.
Can you see them?
Perfect, thank you.
Okay. Sorry, I don't know what happened. With the statins, I'm sure you have all heard about Jean Kuttner's study. Some people have criticized it as not a large enough number needed to treat here, but I think it was a very good study. She is a very real life, practical kind of study. She had English-speaking patients who were over 18 who had been on a statin for at least 3 months, either for primary or secondary prevention, with an advanced life-limiting illness defined as would not be surprised if the patient died within a year. But they thought they would live at least a month, and they had recent deterioration in their Australian Karnofsky performance skill to less than 80%. They had almost 400 patients, half had cancer. They were randomized 1-to-1 to either continue or discontinue the statin. They did a Pearson chi-square analysis to look at the difference between the two groups. The primary endpoint was the rate of death within 60 days, and there was no difference, no statistically significant difference. Those who discontinued the statin, 20.3% died. Those who continued the statin, this is interesting, it was higher, 23.8%. Those who stopped the statin had a longer median time to death of 229 days versus those who continued, it was 190 days. So again, not statistically significantly different, but I don't know, I think those 40 days seem to be clinically significant to me. And Kuttner hypothesized that if we did this for everybody who had a prognosis less than a year, we would save an awful lot of money. They also asked the patients, I thought this was important, less than 5% thought their physician was giving up on them, or that if we stopped the statin now, it meant it was a waste of time, all that time that I took it. And only 11% worried about the unintended consequences of discontinuing it. So what's really interesting, and I don't know if I had that data. Yeah, this data is in here is important. For things like the statins, like this guy, Mr. Hearn, has been taking this drug for decades, so no wonder he's attached to it. So the question I ask is, has this patient had a heart attack or a stroke, particularly in the last 6 months? If the answer is yes, and they can still swallow it, I would say continue it. I'm thinking of that Kaplan-Meier curve where they looked at people who had a heart attack and they broke them into 4 groups of whether they were on a statin before and after, and they had all the different combinations there. And it was just as you would predict. The people who were not on it before but went on it later had lower mortality and so forth. So as you look at the bottom bullet, the Anglo-Scandinavian Cardiac Outcomes Trial, this was looking at atorvastatin, and 8 years after the study was completed evaluating the atorvastatin impact, the patients who had been taking it, but they'd since stopped, still had fewer deaths from cardiovascular and non-cardiovascular disease. So there's a legacy effect from statin therapy. So again, applying this model, how would I have this conversation with Mr. Herndon? I would say, Mr. Herndon, kudos to you for taking atorvastatin all these years. Obviously, it's been providing you benefit because you've not had a heart attack or stroke. But the good news is that research has shown the benefit you accrued from taking atorvastatin all those years was like putting money in the bank. And even if we stop it now, you'll continue to reap the benefits. Research has further shown there is not an increased risk of a heart attack or stroke for people clinically like you. And while they don't cause really major side effects of not having myalgias, it will be one less tablet you have to take. And atorvastatin, particularly if you look at the 80 milligram, that's like bigger than a multivitamin. You would have less side effects such as muscle weakness. So what about the antihypertensives? A meta-analysis of 18 trials found that the risk of mortality was 16% lower during the trial and 15% lower during the follow-up period. And the SPRINT trial showed that targeting a systolic of less than 120 resulted in lower rates of death and major cardiovascular events during, and then again after the trial. So a bit of a legacy effect there too. How would you have this convo? Mr. Herndon is experiencing side effects from his antihypertensive regimen right now, right this very minute. His blood pressure is low normal and he's complaining of orthostasis. So minimally, we should stop one. He's on lisinopril and amlodipine. Now, right now, he's lost 100 pounds, so his blood pressure is naturally declined. So I think he was only on amlodipine 5. That's like a little baby dose. It's like licking the tablet. I would stop it and see what the scoop is. So I think the chances are good. In a couple of days, we can reduce the lisinopril, and then we probably will be able to stop that as well. What about his anti-hyperglycemic drugs? He's had diabetes for a lot of years. He's on metformin, Lantus at bedtime, and Novolog sliding scale. Now, the metformin, he has chronic kidney disease, stage 4, so this drug is contraindicated. I mean, he's 75 years old, I believe. I see people all the time in hospice, 80 years old, on metformin, and it's contraindicated. I would not do that. Get rid of it. The sliding scale, I don't like sliding scale insulin. It's kind of been, it's fallen into disfavor. You're always chasing the blood glucose. You're always behind the curve of what's cooking there. So he's not using it. And I don't think poking your finger 4 times a day is very palliative. So I would say, let's stop the metformin. Let's stop the Novolog sliding scale. And let's sit tight and see how this domino effect affects his blood glucose before we talk about the Lantus. But I do think, I think it's important to know this data because I use this data when I'm talking to patients and their families, and often it is the family, not the patient. If you are all too young, maybe Dr. Mulder and I remember this, but the rest of you probably not so much. The DCCT trial, this was the diabetes control and complication trials in the early 90s. They had like 1,400 patients with type 1 diabetes. They divided them into 2 groups, those who got tight blood glucose control as either insulin pump or multiple daily injections, and the other half had usual control. And at that time, it was regular NPH, split mix, BID, see your healthcare doctor, your doctor or healthcare team every 3 months, and that was the end of it. And within each of those groups, half had no complications of diabetes, and the other half had early complications, so early retinopathy and early onset nephropathy. So what they found is those who achieved tight blood glucose control had a 40 to 60% reduction in the development of complications. And these were microvascular complications because these were pretty young people, actually. So it was the microvascular and a little bit of a positive impact on neuropathy development as well. Now, okay, the trial ended, boom, end of discussion. Fast forward 17 years after the starting of the trial, those who had been in the tight glycemic control arm, despite everybody who's still left standing having very similar blood glucose at this point, those who had had tight blood glucose control, now they're old enough to be experiencing macrovascular complications. They saw a 42% risk reduction in any cardiovascular event and a 57% risk reduction in the risk of non-fatal MI stroke or death from cardiovascular disease. So, what does this mean for our patient? All those years he watched his diet, took his drugs, and monitored his blood glucose again, like putting money in the bank. Now we can loosen the reins. I'm not sure he needs to go out and eat a dozen cinnamon buns here, but we can loosen the reins a little. I have a whole talk called Give the Dying Diabetic a Donut because I think that's ridiculous to be that tight at that point. Go get the milkshake. And we'll monitor him for the signs and symptoms suggestive of hyperglycemia. So we're going to stop the metformin and the Novolog. Let's check the fasting blood glucose 3 times in the next week. So Monday, Wednesday, Friday, let's check first thing in the morning because that blood glucose, the fasting, it reflects the appropriateness of the Lantus dose the evening before. So even, you know what, even if his fasting is 200, I'm okay with that. I mean, we have like 10 million people walking around with type 2 diabetes right now, and they don't even know they've got it. So people can tolerate a blood glucose of 200, and they're generally asymptomatic. And then let's continue thinking about this, and should we reduce the Lantus or maybe even stopping it? And then absolutely stop checking the blood glucose 4 times a day. So how do we have this conversation? Again, enormous credit for following your diet and taking your drugs all these years. Research has shown that tighter blood glucose control starting at the time of the diagnosis leads to an accrued benefit and reduction of complications later in life. You're not even using the Novolog. You've lost a lot of weight. You're not eating like you used to. Given your kidney disease, we really need to stop the metformin. And let's stop the Novolog. Let's check your sugar over the next week or so and make a decision about what to do with the Lantus dose, to reduce it, to stop it, whatever. And in the meantime, we can liberalize your meal plan and stop checking your blood sugar so often. Now let's switch tracks and look at a second patient. Any questions at this point before we rock on here? Okay, everybody looks like they're still awake. That's a good sign. Here we have Miss Judy, a 78-year-old female. She's had repeated falls in the last 3 months. She has a history of breast cancer, hypertension, dyslipidemia, NVAF, but no stroke, Alzheimer's. She's a fast 7C. She lives with her daughter, Laura, in Maryland, because that's where I am. And her son, Frederick, is a lawyer who lives in California. They're always from the other coast, and they're always like a doctor or a nurse or a lawyer or something like that. And they're always highly opinionated. Anyway, Judy is taking donepezil, memantine, lisinopril, atorvastatin, warfarin, a multivitamin, Ferrex, and then the federally mandated calcium and vitamin D. When you suggest slimming down on the drugs, the Laura, the caregiver, is agreeable. But Frederick, on the other hand, goes ballistic and angrily says, "What's wrong with you people? Are you trying to kill her off?" Yes, Frederick, you caught us. We're trying to kill your mother. So any issues here? Yes, yes, yes. What about these cognitive enhancers? So with the cholinesterase inhibitors, they're actually much cheaper than that now too. So we have donepezil, galantamine, and ribostigmine, and more on this group of drugs toward the end of my presentation, indicated for mild to moderate to severe with donepezil, Alzheimer's, and then the NMD receptor antagonist memantine is for moderate to severe. You all know the FAST criteria. To be eligible for hospice, you have to be a 7, at least a 7A. And this is the study that everybody points to. It says, see, these drugs are good even for people with advanced Alzheimer's disease. So I think this is a very well done study. This is by Howard, looking at 295 community dwelling, moderate to severe Alzheimer's patients treated with donepezil for at least 3 months. They had a mini-mental somewhere between 5 and 13, and they followed them for a year. They were stratified and substratified by a bunch of different variables, and they put them into 4 groups. So they were already on donepezil coming into the trial. So there was a donepezil only, memantine only, both donepezil and memantine, or neither drug. So I like how they did this, the outcomes. The outcomes were the score on the mini-mental, and they said a clinically important difference was scoring 1.4 points or higher than the comparator group, whatever that happened to be. And you know how families will say, look, I know her cognition has gone to the devil, but she's easier for me to handle when she's on these drugs. So they were like, okay, let's do the caregiver rated Bristol Activities of Daily Living scale. And they said a clinically important difference was 3.5 points or greater, lower than the comparator. So the patients doing better have a lower BADLS score. So coming into the trial, the baseline mini-mental was 9.1, 9.2. The baseline BADLS, which goes 0 to 60, is about 27 to 29. So again, I'm reminding you what was considered to be the clinically important difference, and here are their outcomes. If you looked at everybody who got donepezil, regardless of the memantine, versus did not get donepezil, that was the only one that met the clinically important outcome point. And you can see their mini-mental was 1.9 points higher than the other group. Memantine did not make a difference with either outcome, and the donepezil sitch did not achieve clinical importance with the BA-DLS. And this impact of donepezil and memantine did not differ significantly in the presence or absence of the other. So again, but here's the big payoff right here. Remember I said they substratified by a bunch of different variables. One of them was the entering mini-mental state score. So they looked at people who came into the trial with a mini-mental of 10 to 13 versus 5 to 9. And only the people in the upper group, the mini-mental of 10 to 13, showed the clinically important difference. And their score was 2.6 points higher. Those with a mini-mental of 5 to 9 did not achieve that clinically important difference. I love this slide with all my heart. This is done by Riceberg, and this is the guy who came up with the FAST criteria. He pulled together all this data. So if you look at the second row, the FAST stage, and go over to 7, and then you go down to the second from the bottom row, the mini-mental state exam score, he's hypothesizing that once somebody is a stage 7, FAST 7, their mini-mental is about a 0. Well, I'm not sure if that's true consistently, but you know what they're not? They're not a mini-mental of 10. So if somebody is appropriate for hospice, they probably are not going to show a clinically important difference. So when you apply this, what's the bottom line? I think, particularly when they're admitted to hospice, with the admitting diagnosis of Alzheimer's disease, the dementia meds are less helpful and more harmful. I do not think they should be given for a patient who's appropriate for hospice with a FAST 7 without a very clear and ongoing benefit seen. I think it gets a little stickier when someone's referred to us in hospice with a diagnosis other than the Alzheimer's, but they happen to have Alzheimer's disease. Like if they have a FAST 6 or 5, I don't know, should we continue it or not? I think that's going to be a case-by-case decision. And if you are going to stop it, this is a drug, you would taper. My general rule of thumb for stopping medication is if it messes with your head or your heart, I probably would taper it. But is Frederick buying what you're selling? No, he is not. So how do you have this conversation with Frederick? It just annoys the heck out of me that, you know, the sibling from the other coast, 3,000 miles away, who is not here, boots on the ground, helping to take care of the patient, is trying to call the shots. Well, you know, Frederick, get your butt over here to Maryland and help your sister take care of your mom if you're so invested in this. Anyway, the SPIKES protocol is SPIKES. So setting up the interview, you want to do it in a confidential location. Perception, how much do they already know? Invitation, how much do they want to know? Give them the information. And then when you say things like, data has shown for somebody in your mom's position, these medications are not really giving any benefit. And if you look particularly at the cholinesterase inhibitors, they are vagotonic drugs, and they lower the heart rate, they cause bradycardia, they actually increase the hazard risk for falling and breaking a hip. And Judy has had 3 falls recently. That's going to be a little upsetting. You're giving them bad news. So people say, oh, do pharmacists break bad news? Yeah, we do. We might not say, you know, you're going to die in 2 weeks, but they do say, you know, I don't think this drug is really helping you, and I think we should stop it. So you have to, I think empathy is the most important thing that we can do. Empathy does not mean you agree with someone. If you might be thinking, I don't quite know why this guy's so upset about this, but you can empathize with them and then come up with your strategy in summary. I just want to point out that deprescribing.org is a wonderful website. They've got all these little cards that you can use for about 6 or 7, 8 groups of drugs that we may deprescribe, and they really do a lovely job with the Alzheimer's drugs. So again, just coming back to summarize this, the deprescribing continuum, I think when you go into prescribing a drug, you need to tell the patient and the family, even if it's a cardiologist who says, oh my gosh, you have to take losartan and metoprolol and atorvastatin and a baby aspirin and blah, 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 until you die. They don't really mean until you die. They mean, you know, until it's no longer appropriate, because at some point these drugs will become inappropriate. So we always have to revisit that. And I think we need to inform the patient about that going into it. So the conversations are very important. Any questions on the deprescribing portion? Okay. So a few tips and tricks about drugs in hospice and palliative care. I cringe when a nurse calls me and says, "Oh my gosh, you have to help me. My patient is all itchy." Oh my God, I hate that. I mean, number one, I'm on the phone. And number two, what do I know about dermatology? I think God bless dermatologists. They're amazing. But I do know this. I do know that a lot of itching, dry skin is a big part of it. So how do we best hydrate the skin, from the inside out or from the outside in? Well, really, it's from the inside out. So better hydration, but in our patients, sometimes that's not really feasible. So what can we do? So, okay, we can try to trap any moisture in the skin and keep it in the skin. So trying to hydrate the skin from the outside in. So what do you do? So the best thing you can do is, if they take a bath or a shower, do it only every other day, because you're depleting the oil from the skin every time you take a bath or a shower. Make it a short one. Make it with warm water, not hot water. Pop them out of the tub, and then don't seesaw them dry. Pat them dry very quickly and lube them up. So if you can pat somebody dry and lube them up within 3 minutes, you probably can trap some of that moisture from the bath or shower into the epidermal layer. But the more occlusive it is, the more oleaginous, the more fatty it is, the better it works. But show of hands, who's interested in walking around coated in Vaseline all day long? Nobody. So yay, Vaseline. So what is an emulsion? Now I'm going to turn you all into pharmaceuticists. It's a mixture of two or more liquids that really are immiscible, meaning oil and water. They don't want to blend together. They don't like each other. So this liquid phase separation. So there's something called an emulsion, and an emulsion can either be oil in water or water in oil. What does this mean? So a water in oil emulsion, so it's whatever the in part is what it feels like. So if it's something in oil, it's going to feel greasy. So the oil is the continuous phase. So you can see the solution or gel, whatever it is on the left, is the oil part, and the red part is the dispersed balls of water within the emulsion. On the other side, we see oil in the blue, and the continuous phase is more like a cream. So it's more not greasy because of that. So why am I bringing this up? Because Eucerin is an oil in water emulsion, so it feels like a cream, water soluble, but it has the oil in it. So it's less objectionable to the patient. Aquaphor is water in oil, so it feels like Vaseline. So my point is, I would try the Eucerin. If you do run into the Eucerin Aquaphor rep and say, I want to get on your mailing list, for years, I don't know how I did this, but I got on their mailing list, and every month they would send me like 100 little samples of Eucerin and Aquaphor to give out to patients. So it's a nice thing to do. You can put them in a big fish bowl on your countertop and let patients take them. Just a word about thrush. Nystatin, swish, and swallow. Everybody seems crazy about this, but you know what? None of you are old enough to remember there used to be a commercial from Listerine that would say, if you're going to use Listerine, you have to swish for 30 seconds. And they had the guy on the TV ad swishing for 30 seconds. And it felt like 3 years that he was doing this. So it takes a long time. So you do have to swish with swish and swallow for 2 full minutes. 2 full minutes. I don't know about you, but I have a Quip electric toothbrush, and it vibrates for 2 minutes. It's 30 seconds in each of the 4 quadrants of your mouth. And every day I ask myself, can I really invest 2 minutes here? And then I say, yeah, because you don't want dentures. Go ahead and do the 2 minutes. But 2 minutes is a long time. A lot of our patients don't have the strength to swish for 2 full minutes. So if somebody has thrush and you don't want to use an oral medication like Diflucan, and they're very weak, I would get a clotrimazole troche, because it's just like a smushy little dosage formulation you can park in the mouth. It melts and it lubes the mouth. But even if you're not going to use Nystatin, swish, and swallow for the thrush itself, if the patient does wear dentures, you want to order 6 ounces of the Nystatin solution. The denture cup holds 3 ounces, so fill it up, soak the dentures for 24 hours, dump it out, refill it, and do it for another 24 hours. Because if you don't do that, it's going to reseed the infection. All right, the most common infectious disease in the world is a urinary tract infection. Obviously, in hospice, we see this a lot. Little old ladies who have relapsing, recurring, simple cystitis. So what can we try? I mean, the most common are going to be Bactrim at a lower dose, Bactrim single strength 3 times a week, maybe just the trimethoprim. Nitrofurantoin's a popular one, but you got to watch the renal function. Fluoroquinolones are not a good bet. Fluoroquinolones are naughty, naughty kittens. But I am a big fan of D-mannose. D-mannose, it inhibits the bacterial adherence to the urothelial cells. It's very popular in veterinary medicine and has been shown to reduce adherence of E. coli, Pseudomonas, and the staph, I don't know if the staph or strep, the zoo epidemicus. So this was a study in 308 women, 18 years and older, with acute UTI and a history of recurrence. So that acutely they were treated with Cipro for a week, and then randomized to either 2 grams of D-mannose powder a day, nitrofurantoin, or placebo. And the recurrence rate was 60% in placebo, 20% nitrofurantoin, and 15% with D-mannose, with fewer adverse effects. I'm going to skip this, but my daughter is also a palliative care pharmacist, and I was telling her about this great data because we use a fair amount of D-mannose in hospice, and she was like, "Oh, Mom, everybody knows for urinary health you should get Eucora." That because she's hip and she's cool, and what do I know? I'm her old mother, right? So I looked up Eucora, and guess what's in Eucora? That would be D-mannose and a bunch of other stuff so that they could get a trade name for it and charge $1 million, but it's D-mannose. So this is, I'm not going to read this to you, but this is from a lovely article in the Journal of Hospice and Palliative Nursing, looking at this protocol called STAMPS, which is a decision-making process in treating any infection in somebody with a serious or advanced illness. It has to do with assessing the symptoms. What are the target goals? What else could we do? What are the medication factors we have to consider, the patient's prognosis, and thinking about opioid stewardship? Another tip, I got this from my sister, who also is a pharmacist, but she is a community pharmacist. She works at a Safeway pharmacy. She's the manager. So she gives 8 billion vaccines a year. And of course, they can give vaccines to children. And kids, of course, are terrified. Of course, I'm in the children bucket because I hate getting injections. But this is something called plastic courage. You can see it's called a shot blocker. You put it against the skin and the needle goes up in that little U-shaped track there. But on the side that's touching the person, it's got all these little bumps. So basically, they feel the pressure of those little pricks, so to speak, and it distracts them from the actual IM injection. And a meta-analysis show it really did decrease the perception of pain. This is one of my favorite things in the world. This is called the oral flow cup. This is for people who have a hard time swallowing. So if you look at it, the spout is on the wrong side of the cup. So if the lid were off, you would see there's a plastic grate in there with holes in it, like when you're straining noodles, a strainer, so to speak. You put water in the bottom or whatever fluid you're using. You put the grate in, and then you put the tablet capsule on top of the grate. And because they have to put their head so far back to get it to flow, because of you can see the guy on the left, the water or fluid comes out as a tidal wave and just takes the tablet or capsule with it. And people don't even realize they swallowed it. That's an amazing tip. Here's another amazing tip. I just shared this with a friend whose brother-in-law has cancer, and he has unrelenting hiccups. This is called Hickaway. This was funded on Shark Tank. It comes in a bunch of colors. You can get it on Amazon. If you use this straw, as you can see here, and you forcibly sip for 3 seconds and then immediately swallow, you do that a couple, 3 times, and I swear to God, it's like magic. Very inexpensive. The other thing is talking about dry mouth. I mean, oh my goodness, dry mouth, if you've ever had it, it's just awful. Every time I get a cold, like now, it's awful to get a dry mouth because you're mouth breathing. Lots of drugs can cause it too. But here's the trick. Here's the tip. Xylomelts. We presented this last year at the Academy meeting, and there was a physician in the audience, a woman, and she said, I texted my husband right away because he had I don't know, some illness years and years before, which left him with a persistent dry mouth, particularly at night. And she said, I told him about the Xylomelts, and she called me to say, he says this literally was a life-changing intervention, this Xylomelt. It's a slowly dissolving disc that kind of lubes the mouth. So there you go. I just wanted to share this with you, and if Dr. Mulder wants, I can send you the 8.5 by 11 version. This is from the methadone paper that we published on the safe and effective use of methadone in end-of-life care. But I particularly like the little chart to the right. I mean, even if you're not heavily invested in doing methadone dosing, which you all should be, you can look at, like, for example, if somebody's on morphine or hydrocodone, look at how much they were on, and then go over to the right on the chart. Are they less than 65 or over 65? And then it's a 10-to-1 or a 20-to-1 ratio. So I really designed this for nurses. So when one of you prescribers says to the nurse, nurses are smart cookies. So they'll call me all the time and they'll say, okay, so Dr. Jones just ordered methadone 5Q12 in my 84-year-old little old lady who's opioid naive. And it's so funny because they kind of lower their voice, like, I don't want them to hear me. And I'm like, is the prescriber there in the room with you? Why are we talking in a whisper? No, he was on the phone with me. Okay, great. And the nurses know that's wrong. And the nurse knows they're going to go up the river too if we give an inappropriate dose. So this is a very helpful. I love infographics. And this just appeals to my sense of the ridiculous. This is vibrant. It's indicated for the treatment of chronic idiopathic constipation. The directions are you swallow this little sucker. As you can see, it's a capsule that vibrates. It's about $2 to $3 a day. And you swallow it, it goes down, and it vibrates and leads to a bowel movement. So it's crazy. It vibrates for like a certain number, like 15 seconds, and then it stops and it goes through these cycles. But I think that's pretty crazy. And I just want to point out, I love intensols. What's an intensol? It's a high concentrate oral solution. So if we have this guy who was on 54 milligrams a day of IV morphine, that's about 160 of oral morphine a day. If we were going to do methadone, how old is he? He is 58. That would be a 10-to-1 conversion. So we would put him on 16 milligrams a day of oral methadone. And then we would give methadone 10 milligram per mil oral solution, 8 milligrams twice a day, and the oral morphine solution. So an intensol is a high concentrate oral solution of a medication. You can put it in the buccal cavity up to 1 ml, prop their upper body up 30 degrees, even if they're not conscious, and they will not aspirate it. So it works really, really well. And people ask me, well, how much of it actually gets absorbed transmucosally in the mouth? It depends on the drug. Like if you look at morphine and oxycodone, they're very water soluble. So at best, 20%. So how does it work? The rest of it just kind of slowly trickles down the throat and gets absorbed like as if they had swallowed it. So it works really, really well. So up to 1 ml, 1.5 mLs, and you can use both sides of the buccal cavity. And just another plea for pregabalin or gabapentin in the management of chronic pruritus in renal disease. So it really works well. This was a study looking at people rating the pain discomfort of itching on a 0 to 10. At baseline, they were a 9.7. Within a week, they were at a 3.7, and they stayed there for months. So this is a great option. Don't forget, with both pregabalin and gabapentin, you have to dose adjust for renal impairment. Any questions on that so far? Okay, well, we have 7 minutes left, so I'm going to really go fast now. Just some of the drugs approved in 24 that I thought were pretty darn interesting. Dupixent. I know you've seen it on TV for things like atopic dermatitis, but now it will be used for COPD. And this is the first monoclonal antibody, the first biologic used for COPD. So it's an interleukin 4 and 13 inhibitor, and that's what drives inflammation. So it's being used as add-on maintenance therapy. It reduces symptom flare and improves lung function over time. So I think this is going to be a big player. Of course, it's going to be ungodly expensive. Cobenfy, xanomeline, and trospium. This is an oral medication for schizophrenia, but it does not really impact serotonin or dopamine, although it has been shown to be a dopamine antagonist in rats, but not so much people. So how does it work? It works as an anticholinergic at the M1 and M4 receptors. So importantly, it doesn't cause weight gain, movement disorders, or the other problems associated with the anti-dopaminergic. And the trospium blocks its effects in the rest of the body. So I think that's pretty darn cool. FluMist is now available as a nasal vaccine, and it's self-administered. So you can write a prescription for it. They can mail it right to the patient's home, and they spray it in their nose. So that's pretty cool too. Neffy, speaking of intranasal, I'm sure you heard about this on the news. This is a new form of epinephrine for a severe allergic reaction. It's like the EpiPen, but it's intranasal. So you inject one spray, you make one actuation into the nostril if they're having a severe allergic reaction, and you can repeat it in 5 minutes if you need to. It's very convenient. It's easier to use. It's the first non-injectable form, and it's approved for adults and children who weigh at least 66 pounds, but they're going to get the indication for 33 pounds and higher. Zonvenil is benzgalantamine. Remember I said I'll talk about the cholinesterase inhibitors later? This is it. This is an oral medication to treat symptoms of mild to moderate Alzheimer's. It's a delayed release tablet taking twice a day. You start with 10 and you can go up to 30. This actually is the prodrug of galantamine. So a prodrug is, you swallow it. The first place an oral medication goes after you swallow it is through the hepatic circulation. So it's converted from benzgalantamine to galantamine, and it's much more tolerable because it gets through the GI tract and then it gets absorbed and goes to the liver. So you have a lot less of the GI side effects such as nausea and diarrhea. Voquenza is for heartburn. This is an oral medication to treat heartburn related to non-erosive GERD, but it's also approved for erosive as well. It's taken once a day, usually 10 milligrams once a day, and you take it, it's approved for 4 weeks at a time. So this is the first drug approved for non-erosive GERD, and it does work differently from the proton pump inhibitors. This drug works by competing with the hydrogen potassium pump, and then reducing gastric acid secretion, whereas the PPIs bind to the gastric potassium hydrogen ATPase via non-sulfide bonds, disulfide bonds. Kinsella, which is donanemab. I'm sure you've heard of aducanumab, was the first monoclonal antibody that was approved for Alzheimer's disease, but that's been taken off market. That is credited with being the absolute worst drug launch in the history of drug therapy, in the history of being alive. So anyway, that's been taken off market. Now we have two on the market, lecanemab, which is Leqembi, and we have donanemab, which is from a different drug company. And both of them work by targeting beta amyloid plaques, which is, as you know, possibly a root cause of Alzheimer's. It's an IV infusion every 4 weeks. And in some patients, when you measure the amyloid plaque levels, you can stop it after 6 to 12 months, whereas Leqembi is meant for ongoing use. Also, Kinsella is every 4 weeks, whereas Leqembi is every 2 weeks, although they are going for a once-a-month approval, probably this month. But Kinsella is likely to cause more amyloid-related imaging abnormalities on brain scans. So we're not sure if that actually leads to clinical problems. Otuvra for COPD. This is an inhaled medication given by nebulizer. First new type of maintenance med for COPD in over 10 years. It lowers inflammation and it's a bronchodilator. So it's a phosphodiesterase 4 inhibitor, which reduces the inflammation like roflumilast. It's also a phosphodiesterase 3 inhibitor, which gives you a bronchodilator effect. So this is a controller, not a reliever. It's only available by NEBs right now, but they're meter dose inhalers in phase 2 trials. CAP vaccine is for pneumococcal vaccine in adults. This is a single IM dose, and it is said that it addresses more serotypes than the other vaccines. It hits all the ones responsible for 80% of pneumococcal diseases, including meningitis. Nexletol, which is bempedoic acid, is an oral med that treats high cholesterol in adults with who are already on a low cholesterol diet. It's already on Nazlazet, which is bempedoic, and ezetimibe, which is the active ingredient in Zetia, taken once a day. So it's a statin alternative, and you can actually combine it with a statin too. And then I want to end with this one, which is Wegovy, which is semaglutide. Obviously, unless you have been off the planet for the past year and a half, these the GLP-1 agonists have just gone crazy. So, they've been approved for diabetes for quite a while, starting with exenatide and semaglutide and tirzepatide and so forth. But now two of them, Zepbound, which is Mounjaro, and the Wegovy, which is also Ozempic, are approved for weight loss. And now tirzepatide was approved for sleep apnea. And you can't go a day without getting another news flash, like they're helpful in cardiovascular disease. And semaglutide was the first one who just got the FDA-approved indication as lowering cardiovascular risk. I think this is great because A, we do have the data to support it, and B, maybe insurance companies would be more likely to cover the medication. You know, they're very expensive, but very effective for weight loss. Tirzepatide, you'll see about a 20%, 22% total body weight loss over about a year, which is pretty impressive. Some people are saying that the GLP agonists are probably could potentially eradicate obesity. So I think that's pretty darn exciting. And the last bit of news is my latest book was released yesterday, and one of our contributors got it in the mail yesterday. I don't have a copy in my hot little hands, so she gave it to her daughter, who apparently thought it was a riveting book. So make sure you read that. And then, speaking of cuteness overload, this is my youngest grandson, and this is his first time on the throne. So I think from now on, every time I go to the loo, I'm going to wear my Spider-Man mask as well. And that concludes my presentation, and I'd be happy to take any questions or comments.
All right, the floor is open for people that have questions for Dr. McPherson. As always, outstanding and beautifully done, and learn something every time.
Thank you.
Just really appreciate that.
Sure.
Questions for Dr. McPherson?
Yeah. Do you have any like pearls tips for patients reluctant to stop their anticoagulants?
Yeah, that's another whole conversation. But, I think you need to look at the data. I think you need to have a frank conversation about the risks and the benefits and say, if it's primary prevention, I would stop it and say it's unlikely to, go on to have a fatal event. But talking about, you've been falling a lot lately. I mean, we get people in hospice on warfarin all the time, and their INR has not been therapeutic in months. So, and it's hard to swallow, and they're a tough stick. So I think just looking at the benefits and the burdens. And I mean, I will send Dr. Mulder, I have a whole talk on this. I'll send him the slides so you can share them with you. And there are 4 cases at the end that you can take a look at, or I'll come back another time and do a half an hour or something if you'd like to talk about that. But it's the whole benefit burden conversation. There's no one magical answer. I think for VTE, that is very much a case by case decision. I think when, particularly in looking at my population, which is primarily hospice, if you look at the risk, the absolute risk of having a stroke from non-valvular AFib. You could. I actually had a resident who did a study looking at the CHAD-VAS score and the HAS-BLED score, and it's about equal. So it's about 50-50 when someone is near the end of life. But if you look at the absolute risk of having a stroke in a year, it's, depending on the risk factor, it's anywhere from 1 to 12%. But they'd have to have a lot of risk factors to score that 12%. But if they're hospice appropriate, our average length of stay is about 2 weeks. So if you take that even 12% and divide it out by 365 and multiply by 14, the chance of having a stroke while they're in hospice is like 0.5%. And anticoagulation with warfarin or a DOAC is going to lower that by about 2/3. So if it's 0.5%, do you really need to lower that risk by 2/3 of more? Do you know what I mean? It's like barely measurable. So anyway, but I'm happy to have that conversation at another time with y'all if y'all want.
Thank you.
There's a question in the chat box here about resources that has compiled the lag time to benefit for medications.
That would be helpful, wouldn't it? Speaking of books, I'm working on another book with a colleague on deprescribing or what's it called? Gold concordant prescribing in serious illness. And that is a part of every chapter. So stay tuned on that. And that's a good point. Maybe my friend and I will pull together a paper looking at the lag time to benefit from each of those chapters. So stay tuned. I'll get on that. I'll put it on the list. But you know how the list goes. If I live to finish the list, I will live forever.
List looks like, yeah. So bottom line is, Rob, no, it doesn't exist currently, but stay tuned.
Yes, exactly.
Can I ask one final question, please?
Of course.
I just wanted to know, is it safe for me to be thinking or telling patients that I'm going to go to methadone here because I love the drug and you've been instrumental in helping me kind of think this way through your lectures. My question to you is, I just want to make sure that I'm not over speaking here, but methadone does not have a abuse profile, or is that not true? Meaning, because that's the biggest pushback that I get when I bring up the med is, oh, it's going to make me addicted.
Well, I think I never say never for first thing.
Right.
But it's very unlikely. I mean, anybody can abuse anything, and of course, but it's not like buprenorphine, though. I actually do think buprenorphine is a better substance abuse recovery drug. I also think bupe is an amazing drug for pain management, and I know we're all not terribly comfortable using bupe. But again, I'll send this to Dr. Mulder if you would like. I have a whole presentation. Actually, it's a 7-part presentation on myths and misconceptions with opioid therapy and what is the scoop behind it. And again, I like having an evidence-based conversation with people, saying, let's look at the evidence of this. How likely is this? So if a patient says, whether it's methadone or morphine or whatever, oh my God, I can't do that, I'm going to get addicted. Usually it's the family that's more concerned than the patient themselves. And I'll say, at first, what do? We get empathetic. I say, I can see why you're worried about that. I mean, good Lord, you can't turn on the TV without hearing about the opioid abuse epidemic problem, death rate that we have in this country. And I'll say, tell me something about your mom. Has your mom ever taken like Percocet or Vicodin after like an outpatient procedure or a dental procedure? And most people will say yes. And then I'll say, how did she do with that? When she used up the medication, did she go a little crazy and start stalking the doctor and breaking into pharmacies and selling her jewelry and stuff like that? And then they giggle and say no. And then I say, well, it's unlikely that she will become addicted to this medication. Of course, there's a difference between addiction and physical dependence. There are many medications that we just can't stop cold turkey because we'd have withdrawal. But 25% of Americans will abuse something in their life. So that's why we keep a close eye on everybody. We use universal precautions of opioid prescribing or controlled substance prescribing. So it's very unlikely, but we keep a close eye on everybody. Sometimes it's hard to convince them. It is.
Thank you.
Do you have time?
Yeah.
You had mentioned epinephrine nasal. Can that, I don't know the milligram dosage of that, but can you use it in like an ACLS protocol for, somebody with VFib or something instead of the 1 milligram IV injectable?
I'm
Like
not
in case you can't like get an IV in somebody who's arresting, can you do a nasal epinephrine? I'm just asking, I'm curious.
I would have to check that out further, but that's a great question. But my inclination would be, if you're running a code, I think IV is going to be quicker. But if you really are literally cannot get an IV started at all, no way, no how, it's better than nothing. But I will certainly check that out. Great.
Interesting question. Well, thanks again. This has been great, and we hope that we can continue to invite you to present to our group. Everybody is, we get really positive comments, and it's practical and helps people in their day-to-day practice. So thanks again.
All right, stay warm, everyone. Bye-bye.